Maybe I can talk now a little bit about ICER, but not the ICER the way that Dr. Bress was referring to it, but rather the Institute for Clinical and Economic Review, which also has the acronym ICER, which I must say does confuse some people that aren't really in the field. It just, there's two different uses of the word. But at any rate, the folks from ICER recently put out a report on cost effectiveness of additive cardiovascular disease therapies. In particular, they covered two relatively recent advances, rivaroxaban, which at the so-called vascular dose was found to be highly effective in the COMPASS trial, and icosapent ethyl due to the REDUCE-IT trial. And maybe I can just turn to Dr. Bress, first of all, to just say, what he thought about the report's findings. Did you agree with it, that they deemed both of those drugs cost effective? And then just your further thoughts on whether we should implement those findings.
Yeah, absolutely. So the ICER group is a high quality group, and I agree with their findings in general. And just to review their findings, the ICER report, and I'm going to focus on icosapent ethyl here, was published last October and used a standard literature-based Markov model, which means they used data from published sources and didn't have access to individual participant level data from any of the trials, to estimate the cost effectiveness of icosapent ethyl versus placebo in REDUCE-IT eligible patients over a lifetime from a payer or health sector perspective. And the model applied treatment effects from REDUCE-IT and healthcare and medications cost data from national and commonly used sources. And the top line result, as Dr. Bott mentioned, was assuming a icosapent ethyl cost of about $133 a month, which reflects a net pricing cost or a reduced cost, which is an estimate of what they believe pharmacies and health systems are paying for the product. The model predicted that icosapent ethyl, compared to standard care, cost approximately $18,000 per quality gained than placebo. And what this means is that use of icosapent ethyl in a REDUCE-IT eligible population was cost effective and well below common US willingness to pay thresholds, and would be considered to be high value according to the American Heart Association and American College of Cardiology. And therefore, the higher medication costs from icosapent ethyl were balanced by health gains from prevented cardiovascular disease events.
Yeah, I think that's a really nice way of explaining it to the audience. And increasingly, I believe physicians will have to keep on top of these sorts of evaluations of cost effectiveness. No question about that. Maybe I can also then just ask you again, Dr. Bress, to talk a little bit about some of the REDUCE-IT cost effectiveness analyses. You and your colleagues have played a pivotal role in performing those, but maybe for the audience, you can just give them a recap of what was presented by Dr. Bill Weintraub at the American Heart Association as a late-breaking clinical trial in 2019.
Sure thing, Dr. Bott. It's been a pleasure for me to connect with you and Dr. Weintraub on this analysis. And what was presented at the American Heart Association sessions last November was a preliminary report of a project that, as opposed to the ICER report, is using actual patient-level data from the REDUCE-IT trial. And we applied a combination alongside the trial and simulation-based cost-effectiveness approaches to estimate the lifetime cost-effectiveness of icosapent ethyl versus placebo in REDUCE-IT eligible patients. The patient-level component, I think, is important because it allows for us to, in a more granular way and more fully capture the effects of icosapent ethyl during the trial on critical costly events like revascularizations, as mentioned before by Dr. Budoff. And the top line results from this analysis were that icosapent ethyl at a discounted price at $125 per month, which is very similar to the cost input used in the ICER report, was cost saving in almost all scenarios, and regardless if treatment effects persisted or decayed in the post-trial period. And what this means, what cost savings means, is that icosapent ethyl offers better health at a lower cost overall when used in REDUCE-IT eligible population over a lifetime. And this is due to the cost savings from averted events offsetting completely the cost of the medication.
Yeah, no, that's a very, very nice summary. And how would you say this compares to, say, the cost effectiveness analyses for the PCSK9 inhibitors?
Yeah, so that's an important comparison. I might start with the fact that Dr. Bott, cost savings in cardiovascular disease prevention, whether primary or secondary, is very rare. The only two interventions that I'm aware of in cardiovascular disease research that are cost savings are treating hypertension compared to not treating among high-risk people, and statins for and low-cost generic statins for secondary prevention. Statins for primary prevention among those with a pooled cohort ASCV 10-year risk of greater than 7.5 cost about $40,000 per quality, just to give you some context. And in terms of the PCSK9 inhibitor analyses, I'll refer to one of the Odyssey outcomes trial that you led. So please correct me if I'm wrong on anything I mentioned. But a similar alongside the trial cost effectiveness analysis of that trial found that alirocumab among patients with a recent acute coronary syndrome with an LDL above 70 on good doses of atorvastatin or Versuva found that overall alirocumab the cost about $100,000 per quality overall in the trial. But among those with a LDL cholesterol at baseline above 100, alirocumab was much higher value, and I believe with the ICER around $40,000 per quality. So when comparing Icosapent Ethyl, a branded medication, to another branded medication, a PCSK9 inhibitor, the value assessment looks very different. Icosapent Ethyl, it looks much more favorable in a value standpoint from the cost effectiveness analysis we have right now.